He was with us about 14 months ago, and we liked him so much, we invited him back. So, Dr. Weber, we'll let you take it. Do you want to make any opening remarks, or just take questions?
Can you hear me?
I'm going to turn it up.
Network okay? How's the volume there?
Could be better.
That's not coming through the speaker, is it? No.
How about that?
Yeah, we thought we were going to get you to come through the speaker system in the room, but that's not working yet.
I'll speak as loud as I can. If that's as good as you can do, we'll get going.
Okay.
Bob,
But
is this device at all active with what we're doing?
It could be easier for me.
Jack?
I must say that Bob and I
I got it.
struggled to get Skype to work earlier in the day. Gosh, the light up there makes me look like I'm testifying before the Supreme Court. How many people are in the room?
We've got HDMI, we've got these options here.
Are there other persons other than those that I'm looking at?
Yes, sir. 21.
21.
And that's about the same number that I got for the prostate support Swedish, which is held monthly. And it's about the same as in Belgium. I can tell you an unusual thing. I'm talking to you on Skype, but I talk once a month to Walnut Creek, California, and run a support group by GoToMeeting, and they have about 20 or so people in that group. So, I would be happy to pick up on any of the issues that you've been talking about during the last hour and try to contribute to them. It works out well for me to do it that way, because I can take the question and try to answer it and then expand into some background aspects of it. But, does anybody have an issue that was brought up that ought to be rediscussed?
Go for it, Reed.
Dr. Weber, my name is Jeff. I've been on this group for a couple of years now. As a senior doctor, what would you suggest to people that are having a tough time finding somebody that they think is a good doctor?
There's a lot of background noise, so could you ask that question again?
I'll try. How can you find a good doctor that treats prostate folks? Because we frequently get new folks that come in here and they say, I can't find a good doctor, and how could we best deal with that?
Boy, that's a tough question. It obviously depends upon who's available and what amount of distance is required in order to get to that person. And I don't know the group in Tacoma that well. I think I recognize a couple names. And I guess kind of, if you were to go to the local physician, you might ask your friends how it's working out and how that particular physician fits with his personality. Tacoma isn't too far from Swedish or the Cancer Care Alliance, so I could name some good doctors that I'm with regularly at the SCCA and also at Swedish. So that's not a terribly great distance to go. Who are the local oncologists who work with prostate cancer? Let me see if I recognize the name.
Doctor, I was treated luckily by a fellow by the name of Steve Bulow up at Swedish. And so I'm not familiar with the doctors locally, but I got to take the train up there, and it wasn't bad to go through treatment at Swedish. So that's what you're suggesting then. There's a lot of good doctors up in Seattle and the Cancer Care Alliance.
Yeah, I have no intention of casting any less than complimentary remarks on your local doctors. I do, however, work all the time with, for example, Dr. Zulo, who's an excellent physician for radiation and seed placement. I work all the time with Bruce Porter and Joe Lilly, who are excellent surgeons. I work with Joe Marquez, who does a lot of MRI work, particularly at initial diagnosis. And I work a lot with Bob Meyer, who is the fellow who runs the CyberKnife machine. I work a lot with Alex C., who's at Evergreen Hospital, who does seeds and radiation. So that's my particular area. I know John Corman very well. He's a good surgeon at the Virginia Mason, and I know Kaz Bazinazian. So those are all people that are in my orbit all the time. Maybe that's...
No, that's very helpful, thank you.
And we do have some experts here at Tacoma. Hi, Dr. Weber, this is Jack Gutsmith. I want to make sure that you understand that we're not asking for favoritism at all, but we do have some pretty good talent here in Tacoma. So what I've done and what I've suggested to the guys is go ahead and see those folks here in Tacoma and then ask for a second opinion among those doctors in Seattle. As you know, my medical oncologist at SCCA, I see urologist, I see a combination of Seattle talent and also Tacoma talent. That's okay with both the Seattle talent and Tacoma talent that you're seeing other doctors for a second opinion. So that might be something that we could rely on more heavily when it's time to make that final decision. See somebody else for a second opinion to see if I'm on the right track. That's what I did. I think that's a good bit of advice. Go ahead.
Well, if anybody is confronted with the need for a second opinion, I'd be happy to correspond by email and make some suggestions in the Swedish area. That's not a bad idea many times to get a second opinion, particularly when there's sort of an in-between issue. I'd be happy to respond. You know what? I'll just maybe as I speak, make people. It's a little bit garbled, but I'll try my best to listen to you and talk. I would say one of the newest developments that is available at Swedish and also at the university is the PET CT scan called the Axumin scan. That's AXUMIN. It recently became available in Swedish and also at the university. Does anybody know what the Axumin scan is?
No.
I don't think anybody's heard of it.
It's very important for you to know that. I don't know whether you folks have access to my commentary that comes out every month, but I did 2 commentaries on the Axumin scan. Everybody may have heard of scans available at the Mayo Clinic. That's choline, and maybe Arizona. That turns out to be the acetate scan. But those are very hard to get to. You have to hide in the Mayo Clinic in Rochester, and you have to go to Arizona. So it's a really big advantage to have these scans available in Seattle. Now, the Axumin scan is a total body PET CT, and its purpose is to help identify where the recurrence might occur when, gosh, it's a lot of background noise. It's designed to try to determine where the PSA rise is coming from after you have had initial treatment and the PSA is not controlled. A typical example of the need for, boy, I'm not quite sure where all the background noise comes from. A lot of it. A typical example of the need for an Axumin scan would be a man who has had a radical prostatectomy, let's say this is a man who had high-risk cancer, the Gleason maybe 8 or 9, maybe he initially had a PSA of 22, so he would be at the higher risk group. And after his surgery, in the next couple of years, he might have a somewhat rapidly rising PSA. So the question comes, where is the PSA coming from? Because it's really important to know that question. The next treatment depends upon knowing where the PSA is coming from. And that's where the off-human scan comes in. It has been FDA approved, and that's an important point, FDA approved people who have rising PSAs. It turns out that, of course, the PSA could be coming from the prostate bed, from the local lymph nodes, from lymph nodes elsewhere in the abdomen, or the bone, and you don't know that. So usually what happens is that a treatment is planned to give radiation therapy to the pelvis. Turns out that in many studies, the use of the acute scan changes the management plan in about 50% of the situations. And it does so by either causing the radiation therapist to expand his field or to discontinue any thought of radiation, or perhaps spot treating, maybe with a cyber knife, a couple spots that are outside of the usual place. So I would suggest that for full information, you might go, and I would be happy to send the copy of the ones on the off-human scan to you folks so you can look at it. But it's a very important new development that is very helpful in making clinical decisions. Is there anybody in the room who has had either radiation or surgery and whose PSA is rising, and the question is coming up as to where it's coming from?
Yes. Yes.
It's actually a fairly common situation, unfortunately, because in high-risk patients, persons who have Gleason 8, 9, high PSAs, surgery and radiation, it doesn't necessarily solve the problem in 30% of the instances.
First time I heard that. First time I heard that.
Really? Well, it's the literature is filled with it, and it is something that you folks ought to know. And it's very easy to come to Swedish to get the off-human scan. It takes an hour or so, and it is a PET CT, total body, looks at everything. So I may talk about that again because it fits in many situations. Any questions that are coming up to mind as I sort of ramble on here?
We had some discussion earlier about the use of supplemental drugs and also things like Lupron that shrink the prostate in order to give some relief to urinary problems. Could you comment on some of that, some herbal remedies or any kind of drugs that would help someone who is having severe urinary problems, can't pee?
And would that be after you had initial treatment?
No. This gentleman has not had any treatment yet.
I see. So is he known to have prostate cancer?
Not yet. He has an increased PSA, no biopsy yet, but he's having severe urinary problems maybe caused by a very large prostate.
Yeah. Well, of course, Lupron and Firmagon would do that, and they'd have to be given as injection every 3 months or so. But in a person who does not have prostate cancer, finasteride, which is, or dutasteride, either one of those they're called anti-5F, they're 5, they interfere with testosterone and the DHT in the prostate. That's appropriate drugs. It was often the case in, say, radiation therapy, and prostate is too big, and you need to shrink it a little bit in order to have a better shot at putting seeds in. That they will use finasteride or Avodart, one of those two, and combine it with a little bit of Casodex. But somebody who doesn't have cancer, I would say Avodart would be a good medication.
Yeah, this gentleman is currently on finasteride.
Uh-huh.
Yeah, but hasn't been on a long time yet, but
it takes a while. I mean, it takes a month or so for it to work. But it will shrink the prostate about 30%. Any
okay.
other thoughts?
Any other questions that you have?
Okay.
We have one here. We have a gentleman that just had a prostatectomy robotic about 6 weeks ago and is having heavy incontinence issues. So other than just kind of waiting it out, what would you recommend to help him with this this problem? It's really getting him down mentally, causing some depression, and he's about ready to go back to work and is really anxious about the effect of the incontinence on him in a working environment.
Has he had a good response to his surgery in terms of PSA?
PSA yet. He hasn't had his first follow-up PSA yet.
Well, I think that gentleman's greatest hope is that over time it will improve, because it does. The occurrence of incontinence after surgery is actually fairly high, but in the course of a year, it becomes in the range of maybe 1 or 2%, being really troublesome. So his best hope right now is to just wait it out and see what happens. If it's 6 or 9 months from now he's just not doing anything, then there are surgical procedures like a urethral sling that helps to control incontinence. But at this point, I think I try to hang in there, because the likelihood is it'll get better. That is one of the biggest problems with. I watched a surgery done by Jim Porter with the Da Vinci machine. Fascinating surgery. It took about 5 hours. He removed the prostate. He took the lymph nodes out. And I watched him try to put the patient back together again after the prostate was taken out. And that is the most challenging part of surgery, because when you take the prostate out, on the lower part of the prostate is the urethra, and it's about the size of a drinking straw. When you take the prostate away from the bladder, in other words, you remove the top of the prostate, you make a hole that's about as big as a 25-cent piece, maybe a little larger. And as I watched that, I thought, wow, that is a really tough job to fit a drinking straw into a hole that's the size of a quarter. And how he did it, and how I guess everybody does it, he began at the edges of the hole and gradually crimped it so it was increasingly narrowed until he could then sew the top of the urethra to this diminished hole, that's a very skill requiring bit of surgery, and is probably the main reasons for having incontinence. You just have to have a really good surgeon. And if you're going to have the Da Vinci robot, you want somebody who's done lots of surgeries with that machine. I remember in one of my support groups, I had harped this a lot. I said, look, if you're going to have a Da Vinci, make sure that the surgeon has done hundreds. And he said he was about to have surgery from his urologist, and he asked him, well, how many of the robotics have you done? And the fellow said, well, I haven't done too many, but I'm getting better at it. He did just the right thing. He said, well, look, Doc, I know that you've done hundreds of so-called open prostatectomies. Just do your regular operation on me and experiment for the Da Vinci on other people. And that's what was done, and it worked out very well.
Bob?
We had a little discussion earlier about the actual anatomy of the prostatectomy, in that it destroys the primary sphincter muscle that controls, normal urination. And so, what about the secondary sphincter muscle? What role does that play?
There is two sphincters. There's one at the bladder neck, and there's one at the place where the urethra hits the prostate. And that sphincter is usually taken out. So you're left with the one at the top. And that's why the surgery has to be done very well.
So does the fact that some guys have no incontinence, or at least it dries up later on, and other guys not so lucky, they have continued incontinence, is that primarily dependent upon the strength of the remaining sphincter muscle, or are there other factors there?
I think it primarily depends upon the skill of the surgeon in making these connections.
I'm sorry, say that again?
I think it depends primarily on the surgeon in making these delicate connections.
Ah, okay. Okay.
Bob?
Yeah.
Hold it right up.
I have a question in regard to robotic against the traditional removal of the prostate. Is there any thing that one's better than the other, or does it all work out the same, or depend on the person's numbers or the age, or has there been any studies on that to say what has been better or more for people in the recoveries and all that?
And you're talking about the comparison of
Removing the prostate, whether it's for robotic or the traditional way.
Yeah. There are lots and lots of articles about that because it's an important question. And I think that in good hands, they're both excellent surgeries. However, I think there is a little bit more time required to recover from the open surgery, and there's a little bit more blood loss, but otherwise, those techniques are pretty comparable, which is why I think the man that I spoke of was very wise to say, well, look, do the open one. That's, you've done that before, you're good at that.
I've heard that before. Thank you. Thank you. I guess you can say thank you.
1 second.
There have been huge arguments as to what is better for the treatment of prostate cancer, that is to say, radiation or surgery. I mean, there's just reams of articles that are trying to make a comparison between the two. And I think it's safe to say that for a low-grade prostate cancer, let's say a Gleason 6 with maybe a couple cores positive, PSA is less than 10, somebody who might be a candidate for active surveillance. But in that group, there's no evidence that surgery is better than radiation therapy. When you're moving up the scale to what we call intermediate risk, those are persons with PSAs greater than 10. The Gleason score has a little 7 in it, either minor 7 or major 7. You might have 4 or 5 cores positive. That's an area that has been much evaluated. And I think at this point, batting average says, if you're comparing radiation therapy as it is normally given, customarily would be the right word, that is to say, a little bit every day for 39 or 40 treatments, there was a big study that compared giving that 7 or 8 weeks of radiation as compared to putting in radioactive seeds and having maybe 4 or 5 weeks of radiation from the outside. And it turned out that the combination of seeds and the diminished length of radiation therapy turned out to be a much superior treatment. When you get to be in the high risk, now we're talking about PSAs over 20, Gleason 8, 9, that sort of thing. Surgery has a very difficult time totally addressing that problem. The recurrence rate in men who've had high-risk disease and have had surgery is in the range of 30 to 40%. So you almost always have to accompany that with radiation therapy. And I've always wondered, well, gosh, if you've got a 30 or 40% chance of having the need for radiation, each of those techniques has its own side effects. Surgery has side effects, radiation has side effects. Why do you compound them? Why not just choose, let's say, radiation and avoid the side effects of surgery? That's an important consideration. And a very honest surgeon will tell that to the patients. They go, I can operate on you, but I want to tell you that there's between 30 and 40% likelihood you're going to need radiation therapy too. And he should make that clear right in the beginning and let you decide which way you want to go.